second speaker, who is also virtual. It's the virtual Michael Edmonds, who is going to talk about a new treatment modality which has also been thoroughly investigated recently, and that is sucrose octasulphate.
Good morning, everyone. I'm very pleased to be speaking at the Renaissance Symposium this morning. Could I have my first slide, please? So I'm talking on sucrose octasulphate and PRONOX, query use in neuroischemic ulcers. I first must declare that Ergo Medical and 30 Technology has supported studies as part of multi-center RCTs in the King's Clinic, and I'm also on their advisory boards. So in the outline, I'm going to talk about sucrose octasulphate. Its other name is nano oligosaccharide factor, NOSF, in the first part of the talk, and in the second part deal with the PRONOX study, which involves the nitric oxide generating device EDIX 110. In detail, sucrose octasulphate is actually impregnated into a TLC matrix, the TLC standing for lipido-colloid technology, which is a jellified matrix of hydrocolloid and fatty substances. So sucrose octasulphate plus the matrix equals TLC NOSF, and TLC matrix with NOSF is the final dressing. Strictly, NOSF is the potassium salt of sucrose octasulphate. How does TLC NOSF work? Well, it inhibits matrix metalloproteinases and interacts with growth factors, particularly those acting on vascular endothelial cells, and thus induces neovascularization. So in the sucrose octasulphate section, I will talk about the EXPLORER study, post-hoc observations, cost-effectiveness studies, and pilot vascular studies. The EXPLORER RCT was a European multi-center randomized controlled double-blind clinical trial. It was an RCT conducted in two parallel groups, stratified into two groups according to the baseline surface area. 5 countries were involved: France, Germany, Italy, Spain, and United Kingdom. And 43 hospital centers contributed from diabetology, vascular medicine, and surgery sources. The indication was a neuroischemic diabetic foot ulcer. The tested group was a TLC contact layer impregnated with NOSF, ergo start, and the control group was the TLC contact layer without NOSF, ergo tool. This is the design of the study. There was a run-in period of 2 weeks. At the beginning of this, an offloading system was prescribed. 2, at randomization, it was made sure that the wound surface area had not decreased by more than 30%. There was no infection. Offloading compliance was established, and the hemoglobin A1C was less than 10%. So at randomization, 126 patients were randomized to NOSF and 114 patients to the control group. And there was a stratification, as you can see, according to wound area, 1 centimeter squared to 5 centimeters squared, and 5 centimeters squared to 30 centimeters squared. Treatment was for 20 weeks, and you can see the visits to the clinic on the slide, and then wound healing was finally assessed at 20 weeks, and then there was a follow-up period. Looking at the wound characteristics and their severity, there were similar values in the control group and the NOSF group with regard to Texas grade 1C and Texas grade 2C, ischemic, not infected, but wound penetrating to tendon or capsule. The median duration was 7.1 in the control group and 7.3 in the NOSF group in months. And there was a similar proportion of patients with duration of greater than 6 months, 40% versus 44%. The median wound area was similar in the two groups, and the proportion of patients with a surface area of greater than 5 centimeters squared was also similar, as was the presence of at least one poor healing prognosis factor between the groups. Regarding the limb arterial status, the proportion of patients with a minor amputation history was similar in the two groups, as was the revascularization history. When we come to the detection of pulses, there was a similar proportion of feet in which neither pulse was detected, and also a similar proportion in which one pulse was detected, and also a similar proportion when two pulses were detected. Specifically, let us consider the vascular inclusion criteria. Initially, the ankle brachial pressure index was to be less than 0.9, but the systolic toe blood pressure should be greater than 50 millimeters of mercury. Toe pressure could not be measured, then systolic ankle blood pressure should be greater than 70 millimeters of mercury. As the study progressed, we felt that we were missing patients who were ischemic but had an ABPI greater than 0.9 because of calcification, medial arterial calcification. So we allowed patients in with an ABPI of greater than 0.9, but they had to have a toe brachial pressure index of less than 0.7, but also a toe pressure of greater than 50. So with regard to those data, if we take first of all the ABPI of less than 0.9, you can see the distribution of patients with an STBP of greater than 50, similar in the two groups, and an SABPP of greater than 70, similar in the two groups. And if we take the ABPI of less than 0.9 with a toe brachial pressure index of less than 0.7 but a systolic toe blood pressure of greater than 50, then the proportion was also the same, 22 versus 25%. In a few patients, PAD was confirmed in other ways. So just going down to the bottom of the slide there, most of the patients' PAD have been confirmed through an ABPI of less than 0.9. A systolic ankle blood pressure has been measured for half of the patients with an ABPI of less than 0.9 due to high amputation prevalence. And a toe brachial pressure index have been required to confirm the PAD of almost 25% of the included patients, that is, those with an ABPI greater than 0.9. As to the results, considering the primary endpoint, wound closure by week 20, the main efficacy analysis on the ITT population, you can see that the healing percentage in the NOSF group was 48%, compared with 30% in the control group, a difference of 18 points. And this led to an odds ratio of 2.60, the p-value of 0.002. And thus significantly more wound closure was observed in the TRC NOSF group. As to the secondary endpoints, time to closure in days by week 20, according to a Kaplan-Meier analysis, the NOSF shortened the mean time to closure by 60 days compared to the neutral dressing. So an ITT analysis, the healing time in the control group was 180, compared with NOSF of 120 days. Time to closure difference, 60 days, and again, this was significantly different. Adverse events were similar in the two groups. Overall, the percentage was similar, 41% versus 32%. Serious adverse events of death There were 4 in the control group and 3 in the NOSF group. As to the local effects, local infection, there were 36 events in the control group and 33 in the NOSF group. And there were 2 amputations in the control group and 1 in the TLC group. These results led to the publication of the paper in Lancet Diabetes Endocrinology, and this may have influenced the IWGDF guidelines in 2019, which stated that we should consider the use of the sucrose octasulphate impregnated dressing in non-infected neuroischemic diabetic foot ulcers that are difficult to heal despite best standard of care. Following this paper, there was a further paper entitled Optimal Wound Closure of Diabetic Foot Ulcers with an early initiation of NOSF treatment, a post hoc analysis of the EXPLORER study. And this looked at the wound closure rate according to wound duration categories and treatment. There were 4 quartiles of wound duration, and you can see that the healing rate was greater in the NOSF group in all of the quartiles, but particularly marked in the duration of less than 2 months, 71% versus 41%. When we looked at wound closure rate according to quartiles of wound area, we saw a similar distribution with an increase in healing in the NOSF group compared with the control, and this was present throughout all quartiles of wound area. Focusing now on other parameters and considering age group below 70 and above 70, still there was increased healing in the NOSF group. When we consider BMI of either less than 30 or greater than 30, again a similar increased healing in the NOSF group. And also looking at the history of limb revascularization or history of amputation, again increased healing in the NOSF group. In each subgroup, more wound closure occurred in the TLC NOSF group. Now focusing on the level of limb ischemia post hoc, ITT. If we go to the left of the slide, we can see moderate ischemia. This was defined as an ABPI of less than 0.7 or a TBPI of less than 0.5. And again, you can see increased healing in the NOSF group compared with the control, a 13 points difference, 36% increased healing. And also there was a similar result in the mild ischemic level, ABPI between 0.7 and 0.9, or a TBPI between 0.5 and 0.7. Here where there was a 20-point difference and on percentage, a 74% healing. So the results observed in the limb ischemia severity subgroups were compatible with the significant NOSF effect overall of the wound closure rate. And in each subgroup, more wound closure occurred in the TLC NOSF group. A pilot study has been carried out looking at transcutaneous oxygen pressure in patients with neuroischemic foot ulcers treated with the sucrose octasulphate. This is by Professor Lazaro Martinez and his group. The objective was to evaluate the possible improvement in the microcirculatory status in patients with neuroischemic DFU with the dressing. And the clinical results were concordant with the previous EXPLORER evidence. There was a significant decrease in wound size at week 4, going from 1.30 to 0.5. There's a significant improvement in wound bed within the study, 4.2 points to 5.4 points, and there was a median healing time of 8 weeks. Now, looking in detail at these figures, You can see the individual results for the patients on the left side of the slide, and you will note the transcutaneous oxygen readings for day 0, blue, and for wound healing, red, and they were higher on each occasion at wound healing. And then you can, on the right side, you can see that there was a significant difference in the TCPO2 at 0.05 at week 8, and at wound closure a p-value of 0.01, with a final wound closure value of 45.27. There have been 3 cost-effective models carried out, one in France, the UK, and Germany. They have demonstrated that Ergostart is cost-saving compared to a neutral dressing. It is the dominant strategy over a neutral dressing in these models, with better healing outcomes for less treatment costs. And the sooner the treatment is initiated, the better are the outcomes in terms of clinical benefits for the patient and in terms of savings generated for the health system. NICE has carried out cost-effective studies, and in the model comparing treatments of patients with Ergostart versus neutral dressings, the number of healed wounds per 1,000 patients at 1 year was 473 with the neutral dressing, but 653 with the Ergostart. And the cost of amputation events per patient per year was £272 with the neutral dressing, but £137 with Ergostart. Quality adjusted life years, QALYs, were also calculated, and you can see that they were increased in the Ergostart group. And then spending per patient year was also calculated. In the neutral dressing, this was £3,102, compared with £2,660 in the Ergostart. This was a £435 savings over 1 year for the healed population, and £342 savings when one considered unhealed ulcers. So, in summary, Ergostart treatment range gives better healing outcomes and saves on treatment costs. There was a reduced healing time, reduced dressing changes, nursing time and complications, and it was less expensive and the more effective dominant strategy compared with neutral dressings. So in summary, in the EXPLORER study, TCR-NOSF was shown to reduce healing time and heal more wounds compared to neutral dressings. The cost-effectiveness studies have shown that TLC is a cost-effective treatment option compared with neutral dressing, and NICE has recommended to use Ergostart as a first-line treatment for DFU patients. If 25% of people having treatment for DFUs use Ergostart instead of a non-interactive dressing, then NICE forecasted that the NHS may save up to £5.4 million per year. I'm now going on to the PRONOX study, nitric oxide generating device, EDX110. And this was a trial to assess the efficacy and safety of EDX110. Nitric oxide generating device was used in the treatment of diabetic foot ulcers compared with standard of care dressings. NO may play an important part in ulcer healing. There are 3 recognized sites in the action of NO. The vascular system, as NO influences blood vessel dilatation and stimulates angiogenesis. In inflammation, as NO can influence the host immune response. And in antimicrobial activity, as NO demonstrates potent broad-spectrum antimicrobial activity. EDX110 is a bilayered device. The primary layer is a sterile sodium nitrite impregnated polypropylene mesh. The secondary layer applied on top of the mesh is a hydrogel, converting the sodium nitrite to NO. So this is how it works. It's a bilayer dressing. The primary contact is with the sodium nitrite, and then with the hydrogel dressing. This leads to the release of NO, and this has an effect on blood flow, increases blood flow, has been shown in vitro studies, and also in vitro studies have demonstrated a potent antimicrobial action. The objectives: to evaluate the efficacy of the NO-generating gel dressing to stimulate healing in foot ulcers compared to standard of care dressings, and to determine the safety and tolerability of the NO gel dressing on diabetic foot ulcers. The PRONOX study was a multi-center, prospective, observer-blinded, parallel grouped, randomized controlled trial of the gel dressing versus current standard of care dressings in foot ulcers treated for 12 weeks. And patients were recruited at 10 MDT foot clinics in the UK. The primary efficacy measure was the percentage ulcer area reduction from baseline, the PAR, at 12 weeks. At each clinical visit, ulcers were photographed using the silhouette system and the area calculated. Images were sent for ulcer area measurement to a blinded independent wound care expert. Secondary efficacy measures included percentage ulcer area reduction from baseline at 4 weeks, proportion of ulcers healed at 12 weeks, and proportion of ulcers with greater than 50% healing at 4 weeks. Inclusion criteria: full thickness foot ulcer, not penetrating to tendon, periosteum or bone on or below the malleoli, cross-sectional area between 25 and 2,500 square millimeters, present for greater than 14 days. There should be normal perfusion with palpable pedal pulse or moderately ischemic down to an ABPI of greater than 0.5. The study was open label. Treatment allocation followed computer-generated, center-stratified randomized list in blocks of 4. Centers were unaware of this, and participants were randomized 1-to-1 to the EDX group or the control group. 217 ulcers were screened. 148 ulcers entered the study finally, 75 in the EDX group, 73 in the standard of care group, and all patients received appropriate debridement, offloading, and infection control as judged by the PI. As to the results, looking at the percentage wound area reduction at 12 weeks in the ITT population, you can see, looking at the mean, there was a difference of 58.7 to 37.0, and the median 88.6 for EDX compared with 46.9 for the SOC. And these differences were significant, p 0.016. Looking at the percentage wound area reduction at 4 weeks in the ITT population, EDX was 45.4 compared with 31.7 on the mean, and on the median 53.7 compared with 34.4, and this was not significantly different. This plot demonstrates the median percentage wound area reduction and thus healing progression for both study arms. The PRONOX is in red and the standard of care in yellow, and you can see that EDX achieved greater healing in 4 weeks as SOC standard of care achieved in 12 weeks. Go looking at that graph. What were the key outcomes? Well, EDX improved healing rate and reduced healing time. So looking at the 12-week median percentage area reduction, according to the ITT population, there was a difference of 89% compared with 47%, which I've already mentioned. And in the PP population, a difference of 99% versus 52%. When we looked at the 12-week healing, the values were 40% versus 26% on the ITT, and on the PP, 49% versus 30%. However, looking specifically at the ITT population, there was a difference of 89 versus 47% ulcer area reduction at 12 weeks, and this, as I previously mentioned, was significant at p equals 0.016. So the primary endpoint of evaluating the efficacy of EDX 1-110 dressing to stimulate healing in diabetic wounds was met. Just looking at now a cohort analysis regarding infection status, if you just look at the top part of the graph at the infected patients, and you can see that there were 20 EDX patients and 22 SOC. Yet we got 45% healing in the EDX group and 23% in the SOC group. So EDX virtually doubled the healing rate of those ulcers infected at baseline compared to SOC. However, this did not reach significance. As to the safety, the number of AEs was similar in the two groups, as was the number of SAEs. The SAEs related to the ulcer were slightly higher in the SOC group, and these were related to infection. There was one minor amputation in EDX, two major and one minor in the SOC, and one death in the SOC. This study led to a publication in Wound Repair Regeneration, and you can see the contributors to the paper and also the contributors in the 10 MDT clinics, leading to this paper of the multi-center randomized control observer blind study of nitric oxide generating treatment. So in conclusion, the primary endpoint for evaluating the efficacy and safety of the PRONOX dressing to stimulate healing in the diabetic foot ulcers was met. And the efficacy results in both the ITT and the PP populations, together with the robust safety profile observed in this study, support the use of the EDX device in the treatment of foot ulcers, including neuroischemic ulcers. So, are we in the renaissance in foot care? Well, I would put forward that the EXPLORER study with the nano oligosaccharide factor leading to increased healing, and the PRONOX study with the nitric oxide generating device, the EDX, also giving a positive result. These were two really valuable randomized controlled trials, and they probably do support that we are going into this renaissance in foot care. Thank you very much for listening today.